Hello all, this is me and my Shaka Khan hair, and we are talking today. My hair kind of has a personality of its own going on today, so maybe it is we are talking about different forms of infection today. And so the next form of infection that I'd like to talk to you about is human immunodeficiency virus infection. So I'm going to share my screen so you can see what I'm talking about. Sorry about that. Okay. So first of all, we need to understand that at this point in time, HIV infection has no cure. We are making some strides. There are some different therapies that are being developed to combat COVID that are being cross-applied and tested to see if they can cure HIV. So there is some significant hope. There's a lot of cross collaboration, communication between teams that are working on COVID and teams that are working on HIV to see if we can't cure HIV. A lot of the reason why and I know that sometimes it didn't feel like COVID response was really fast because we were living in it at the moment and it changed our lives significantly and it felt really slow. But we actually kicked COVID pretty fast in terms of when it comes to like antiviral therapies and immunizations. And a lot of that has to do with the HIV teams were talking to the new COVID teams and like, this is what we know, and spreading that information over to be cross-applied into COVID land. Now they're hoping that COVID land will be able to yield some more insights and some better treatments and maybe perhaps a cure for HIV. So it does cause physical disability. It's a lifelong chronic condition and it affects everybody a little bit differently, but it will impact every social determinant of health that someone has. So social, emotional, economic, and spiritual well-being, as well as physical. So like the whole person, if we as nurses are focused on holistic care, the whole person is impacted by an HIV infection. The stigma associated with HIV can lead to discrimination. It can result in social isolation. The physical impacts can result in dependence. This makes people really super frustrated. It changes their self-image. They lose control over what's going on, not only with their body, but with their life. And it changes economic pressures. Ultimately, what will happen with a person who has HIV, it will lead to their death. Now, they won't have a raging HIV infection that is is not going to be the cause of death listed on their death certificate. However, unless there's some sort of traumatic accident, they will most likely develop an infection that we can fight off like nobody's business, like fighting something off in your sleep. Yes, we do have this constant sort of immune system, like alerting virus or immune system control system kind of always going on in the undercurrent. People with HIV infection and acquired immunodeficiency syndrome, which is what HIV infection turns into, don't have that. And so they will get an infection that most of us can fight off. Like we don't even have to fight it off. It just is a non-issue for us because we have healthy immune systems. And that will lead to their death. So HIV is transmitted through contact with certain bodily fluids, blood, semen, vaginal secretions, and breast milk. More often than not, for a while, it was really a huge deal for blood. And it actually, for a very long time, and I have to make sure that I will look this up before I talk about it in class, but for a very long time, gay men were not allowed to donate blood because of the risk of transmission of HIV. Like they were HIV asymptomatic, and so we assumed that of every gay man, and if you were openly gay and you were willing to disclose that on your form, you were not allowed to donate blood. HIV is not spread through casual contact, so hugging, dry kisses, shaking hands, sharing eating utensils, using toilet seats, unprotected sex with an HIV-infected partner is the most common mode of transmission. Routine screening of blood donors have improved blood supply safety. Part of that screening process is, are you a gay man question? But the other part of it is they really have been able to develop some really solid blood tests, and they screen all of the blood regardless of your sexual preference. And so there have been movements in the very recent past to be able to have that question removed from the questionnaire. If you get HIV from work-related stuff, it's a puncture wound. Needle sticks happen, people. So puncture wounds are the most common means of HIV-related or of transmission in the workplace. You can pass HIV, a pregnant mother can pass HIV to their developing fetus. It can happen during delivery, or it can happen while they're breastfeeding. On average, 25% of people born to women with untreated HIV will be born with the infection. And treatment can reduce that rate of transmission from 25% to less than 2%. So if we can get some good interventions going, that's all the better. So quick patho about HIV. Immune problems start when the CD4 T cell counts drop to less than 500 cells per picoliter. So severe problems develop when people have less than 200 CD4 T cells per picoliter. Our normal range is 800 to 1200. So if we're just about half, we're going to start having immune problems. And then the severe problems are when there are is like 25% of the T cells. Insufficient immune responses allows for opportunistic diseases. So clinical manifestations of HIV infection, this is a continuum. So what people will have is they will have an initial infection. So this initial infection happens, and it ends up being like mononucleosis. If you've ever had anybody who's had mono, the symptoms are very similar. So people will have fever, swollen lymph nodes, sore throat, nausea, malaise, headache, muscle joint pain, diarrhea, diffuse rash. People may think that they have mononucleosis. It also kind of represents a little bit of, it sounds a little bit like influenza without the cough, right? Without the coughing and the profuse amounts of mucus that are coming out of your schnoz. It usually happens, these symptoms usually come about 2 to 4 weeks after infection. And this time right here is when they are super highly infectious. So they think that they've got mono, or they're just kind of run down, but this is the most likely time that they're going to be passing that infection to another person. So if for whatever reason this phase evades their realms of realization that they need to get some help, left untreated, a diagnosis of AIDS is made about 10 years after that infection. So you will go from acute infection to this sort of like asymptomatic, limited signs. They may still be continuing in high-risk behaviors such as unprotected sex, and then or unprotected intercourse. And then so this is where that 500-ish number that I was talking about in the patho slide, this is where a person's at in that 500-ish asymptomatic infection. Then as their CD4 T cells decrease even further to like that 200 per picoliter, this is where we have an advanced HIV stage. The symptoms become really bad. They have a constant fever. They have frequent night sweats, chronic diarrhea, recurrent headaches, really super tired, and then they end up with opportunistic infections. So what will happen is if we can't get a hold on that HIV infection when it's right around 200, then the client will be, as their CD4 T cells decrease even more, the client will become diagnosed with AIDS, which is acquired immunodeficiency syndrome. And that diagnostic criteria is established by the CDC. They basically have little to no immune system because of the compromise. They'll end up with huge amounts of opportunistic infections, opportunistic malignancies, cancer, and then they'll end up having a wasting of their body tissue. Not like elimination waste, but like they'll lose muscle tone and they'll lose skin tone, and they just become, these people really do become skin and bones. In addition to all of these metabolic changes, where they're not really processing calories because of the chronic diarrhea and things of that nature, because their electrolytes are all off and their calories are all off, they will have cognitive changes as well. So opportunistic infections associated with HIV, these are also, some of these are infections and some of these are malignancies. This leukoplakia is under the tongue there. It's an oral hairy leukoplakia. We have oral thrush. Thrush is also known as candidiasis. This is why I usually can't say candida, because I'm always wanting to go candidiasis and thrush. You can have, this is how it looks in the mouth. You can also have thrush in other areas, but we call them yeast infections when they're in other areas. So you can have them in skin folds and you can have them in peri area, but we call that yeast infection instead of thrush when it's there. Kaposi sarcoma is a malignancy. It's an opportunistic malignancy, and the person ends up having these, they look almost like little bruises all over, but they're not. And then there's also a pneumonia that people are more susceptible to called pneumocystis jirovecii is the infectious organism that causes it. It's a pneumonia that most all of us with an intact immune system can fight off easily or keep at bay. It's not something that we really worry about, but the people who have HIV need to be. So when it comes to interprofessional care of these clients, we're going to be working with the team to monitor disease progression, immune function, and manage symptoms. We will be helping, the medical team will have some ART therapy, that is the HIV suppression medications. We will be preventing, detecting, treating opportunistic infections, also educating the clients on what to look for. We'll work with them to manage symptoms. The team will prevent or decrease the complications of therapies. Sometimes the decrease of therapies is not great, or the therapy side effects aren't great. And at that first patient visit, we're going to be gathering a baseline and helping to establish rapport and using the client to help develop a plan of care, a complete history and physical exam. And then they really get we start teaching, and then we teach, and then we reteach, and then we teach again, and then we get some, and then we have them give us teach back, and then we teach some more about the spectrum of HIV treatment, preventing transmission, improving health, and then family planning. So for drug therapy, the main goals is to decrease that viral load, and by decreasing the viral load, we will hopefully maintain and or increase those CD4 T cell counts. We're preventing HIV-related symptoms and opportunistic diseases, delaying disease progression and preventing HIV transmission. So the main goals here, part of what we need to be educating on is the drug interactions and any safety problems. St. John's wort and ART do not go together. There are other over-the-counter drugs like antacids, proton pump inhibitors, supplements that don't go well with antiretroviral therapy. And then so we really do have to be partners with pharmacy, with pharmacists to really make sure that people aren't accidentally canceling out their antiretroviral therapy with a Tums. We also were going to be helping prevent those opportunistic diseases. We can help them delay onset by using adequate measures, and then effective management has significantly increased life expectancy. So they still have a very real understanding that HIV will be, or some complication from HIV will be what takes their life. What is different is HIV is not going to take their life in 2 or 3 years. People can live with good antiretroviral therapy and good management. They can live for 20, 30, 40 years. So pre-exposure prophylaxis, otherwise known as PrEP, is a comprehensive strategy to reduce chances of acquiring HIV infection in people at risk. So what people are doing is they are taking part of an HIV antiretroviral regimen daily and using other proven prevention interventions to be able to prevent developing HIV or contracting HIV. So I'm going to stop sharing now, and I'm going to stop recording, and then we're going to go into nursing management of HIV.